It's a wild ride to find out you have leukemia, and you go from somebody who's healthy and active and surrounded by people you love, and you're kind of put in this unfamiliar environment. I didn't think much of it, and finally went to a bike race at the very end of the season. All of a sudden started having chest pain, and so went into the ER there, and they found a pulmonary embolus. So I'd had a blood clot in my lung. But of course, that was because of the leukemia that I didn't know about. And I was air flighted to Nashville, to the Sarah Cannon Institute. I think the more you know, the worse it is. I think if I wasn't a physician, I don't think I would have understood the gravity of having a pulmonary embolus at the same time as a low platelet count. We're so subspecialized now. I think some people think, well, you're a doctor, you know all this stuff. Boy, that couldn't be more, further from the truth, because in all reality, medicine's so subspecialized now. I trust you. Give me the options, we'll make decisions together, but what I don't want to do is try to look up everything myself and second guess you. I really want to feel comfortable that I've came to a leukemia center, I've come to somebody who's a known expert. Dr. Strickland actually started presenting this trial with me the very first day. He came in and said, I've just started this new trial. I'm excited to see if you're a candidate for it. As soon as I was found to be a candidate for it, they were over there having me sign the final paperwork, asking if I had any questions. And the very next morning, they walk in with this bottle of pills and they say, here it is. That care that I received in the hospital, and even the subsequent care in the outpatient setting, has changed everything for me. I got a very unique look at what it's like to be on that exam table or in that hospital bed. And I really understood the importance of nursing, the importance of compassion, the importance of a doctor walking into a room and dragging a chair up and sitting their butt in the chair, and you just feel like there's a conversation that happens. I saw what a difference it made when the providers that walked in and they had a conversation with me about where I was at in my disease and my treatment plan. I felt so comfortable with Dr. Strickland. I just felt like when he entered the room the very first time, he laid it all out. I felt like there was nothing left off the table. From day one, he stepped into the room and said, we're going to look for markers. This is kind of what I'm thinking, and there's even some newer drugs for these different markers. And so we sat down and talked about those markers probably within a day or two of the bone marrow as they started to come back.
The biomarkers can definitely help to guide the decisions on therapy. Our traditional therapies are kind of like going to battle with a tank. Tanks can be very effective, but they're not very specific. And so some of these newer therapies, these targeted therapies like FLT3 inhibitors, menin inhibitors, IDH inhibitors, all of these therapies are kind of like adding a sniper to the mix. And hopefully by going to battle with maybe both tanks and snipers, if you will, hopefully we can have a more effective outcome. I think it also has some implications as far as where is a patient presenting and where is that initial bone marrow biopsy being done. And whether or not the hospital system at that time has access to those tests. So it's not uncommon when a patient does present to us after having maybe a bone marrow biopsy done at another outlying hospital, that we do not uncommonly have to repeat the bone marrow assessment to ensure that we get that testing. And so that does sometimes lead to an extra procedure. It's all of us, all of the providers that are touching these patients, that are coming in contact with them, really advocating with the hospital systems, with the pathology laboratories, to really ensure that we do get this testing, because it is just critically important in the decision-making process that we have for these patients.
I think it's a very, very anxious time. But at the same time, I found hope. Some of these findings that, I could have found out I had multiple mutations, and that, I was a candidate for none of the new drugs, and that we were going to try chemotherapy. And then if that didn't work, here was the backup, and here was the backup for the backup.
It's such an overwhelming time for many patients. In acute leukemia in general, I think is kind of cruel in that way, in the sense that, patients don't go into the hospital or the clinic expecting to have that diagnosis. They walk in with some non-specific symptoms and often think there's something else. I must have a cold, I must need antibiotics, or maybe they are having chest pain, maybe they think it's their heart. I think it's really just trying to navigate, and walk hand in hand with the patient and their families as we get this information. What are we looking for? What is it going to mean? How are we going to use this information?
In no way, shape, or form did I feel like, I was being experimented on, or anything of that nature. I felt very comfortable with it. As the trial has gone on, I have loved it. I probably get to see his clinic staff a little more often than the average AML patient who's in remission. I get to have a bone marrow every 3 months, which is probably not on everybody's bucket list, but a small price to pay.
I think the biggest thing is talking with your doctor, talking with your oncologist, and asking that question. Patients need to be informed and empowered to ask the question about, is there a leukemia center near me? Where is the nearest leukemia center near me? And what are my trial options? And so trying to get away from this idea of people thinking they're so-called guinea pigs and they go into a study, and realizing that we're not here trying to experiment on patients. We're here trying to offer them availability to the most cutting-edge therapy that they can have access to. And that's really where my passion is.
If I put myself on the other side of the screen, and I'm a patient that just gets diagnosed, what does that mean? What would I want to see? I got to tell you, where I'm at today is something that I would have loved to have seen in that first month of diagnoses. And here I am, a year and a half out. I run a full practice at a hospital. I just rode 80 miles last week and am set up to do it again this week on my bike. I'm an active member of my church. I've been able to go back into that. I'm an active member as a coach on the local mountain bike team. And I've been able to do all that again. Me and my wife travel. We love to travel around the nation and see all the sites with our dogs and our kids. And I've been able to do all that again. I wish I could have known that was possible right out of the gate. And so I think if I saw a survivor a year and a half in saying, hey, I just rode 80 miles on my bike last week, and I'm back to work, and I'm back to church, and I'm back to teaching and coaching, I think it would have given me a lot of hope. And so I hope they can derive that from my story as well.